Thanks for the invitation and for organizing a wonderful meeting, Maria. I wish I could be there with you physically. The Global RB study started in 2017 with the creation of the RBNet and the workshop that was held in Hyderabad, India, back then in 2017, including clinicians from RB centers from the UK, India, and several countries from Sub-Saharan East Africa. In this presentation, we'll focus on sub-analysis that were done on those continents, so Europe, Asia, and Africa, and then zoom in and show data from 3 representing countries from each continent. So Europe first. In Europe, we found that the incidence of RB is actually higher than we thought. So dark red represents higher incidence, and this analysis was done by Andrew Stacey. The historical reported incidence was believed to be between 1 in 15,000 to 1 in 18,000 live birth. We found it to be higher, so 1 in 13,844. And the only significant risk factor for higher incidence per country was positive family history of RB. So it seems that the genetic pool of RB is on the rise in the European continent. Richard Bauman did the European outcome sub-analysis. A total of 483 patients from 40 countries were recruited, nearly 17% from high-income countries. So all-cause mortality was 7.5% of children. Purely from RB was lower, 2.5% of children. And risk factors for death, similar to our analysis on the global cohort. So extra versus intraocular RB at presentation was a risk factor, and independently middle income versus high income country origin. Overall, 58% of children underwent enucleation over the 3 years of follow-up. Risk for enucleation was determined by disease stage, as you can see here in this Kaplan-Meier curve. So CT 1, 2, and 3. So disease stage and laterality, but not economic status. In conclusion, even within a wealthy, rich continent such as Europe, economic factors may influence survival, but not globe salvage rates. The majority of children still lose an eye. Next, Asia. Russia and Turkey included again in this sub-analysis, both on the border. Analysis done by Swati Kaleki from Hyderabad, more than 4 times the number of patients compared to Europe. The continent was divided into 5 regions as follows: Central, East, South, Southeast, and West Asia, with most cases from South Asia, including India, over 1,000 patients. A few of the countries that participated in the presentation study did not participate in the outcome study, therefore they're not marked here. Overall mortality, 14.4%, 8% died from RB, highest in the Southeast Asian region, so the highest curve, just over 24%. And risk factors for death were not analyzed here in this study. Enucleation, so 59% of the cohort underwent enucleation, whether primary or secondary, similar to the results in Europe. Highest rate, again, in Southeast Asia. Okay, so 73% underwent enucleation. In conclusion, a significant heterogeneity in treatment outcomes of RB between the regions of Asia, so it's a different way to analyze this subcohort. Southeast Asia had poor outcomes compared to the rest of Asia. Finally, Africa. From a publication from 2021, so originally from the 2017 presentation study, we compared Europe to Africa in terms of distance traveled by patients and found that while the entire European continent is covered, in Africa, only children that live in proximity to the center eventually reach it, and that too is in a late stage. Sub-analysis done by Thamana Nishat together with Andrew Stacey from Seattle, 41 African countries, 958 patients, more than double compared to Europe, and less than half compared to Asia. Since previous analysis focused on death cases rather than presentation of the survival, I will present in a similar manner. So this Kaplan-Meier shows the survival probability Overall, the death rate was 33.8% after 3 years after retinoblastoma diagnosis. On Cox regression analysis, it showed higher risk of death with the most advanced clinical stage, so CT4 versus CT2, nearly 7 times increased risk. Analysis for enucleation was done using a different method. So what you see here is the cumulative incidence plot with separate curves for enucleation only, and death, another plot for death with globe still intact. So potentially these patients could undergo, if they were alive, they could, according to calculations, could undergo enucleation. The risk of losing an eye was relatively higher compared to other continents, 72.6% after 3 years. And high risk of enucleation was associated with higher clinical stage compared to CT1, as you can see. In conclusion, the outcome of disease in children with retinoblastoma in Africa is poor compared to results in other parts of the world, and requires a prompt intervention by increasing efforts to improve survival and eye salvage outcome. And this is a summary, a comparison of the continents. So enucleation similar between Europe and Asia, higher 72% in Africa, and you can see the significant difference in mortality when you compare the continents. Now I wanted to zoom in and look at 3 countries: UK, a rich high-income country from Europe; Burkina Faso in the northwestern part of Africa, a low-income country; and Afghanistan in the far eastern part of Asia, a low-income country, one of the few low-income countries in outside Africa. So while in the UK, London and Birmingham, both centers, all have all diagnostic and treatment modalities, as you can see here, needed to diagnose and treat RB. In Burkina, they have imaging, appropriate imaging. They do enucleation and have a pathology service and can treat with systemic chemotherapy. In Afghanistan, there is no RB treatment center. Whoever can goes to the neighboring country, Pakistan, for treatment. In the UK, according to incidence calculations, one would expect about 50 new patients a year. In 2017, 51 were reported by the 2 centers I mentioned. In the mean age at presentation, that was 19 months. All patients presented with intraocular RB, none with distant metastasis. And after 3 years, all were alive. In Burkina, one would expect about 60 patients a year. In 2017, only 91, less than half, were reported, and they presented to a single RB center in the capital. The mean age at time of diagnosis was 34 months. 23 out of the 29, the majority of patients presented with extraocular disease. 17, again, more than half, with distant metastasis at time of diagnosis. And after 3 years, 19 out of 29 were dead. 1 was lost to follow-up. And finally, in Afghanistan, there are about 80 new cases a year by calculation, but as mentioned, there are no treatment centers for RB. We linked with the National Organization for Ophthalmic Rehabilitation, NOR, in short, which has 4 centers in 4 main cities in Afghanistan, the main branch in Kabul. NOR centers treat basic ophthalmic disorders such as cataract, glaucoma, etc. They do not treat RB, but can make a diagnosis, and then patients, those who can, cross the border to the neighboring country, Pakistan, hoping to find a treatment center. What we did is we collaborated with Afghani and Pakistani colleagues. We developed an RB referral pathway, which we called the RB Silk Road, linking patients from NOR to specialized RB treatment centers in Pakistan, and assisted in making the diagnosis using telemedicine and attempting coordination between the centers. This was the first patient, a 9-year-old Afghani child who, I'm afraid, did not make it. We monitored patients for a year, from May 2023 to April 2024, and I'll present our findings from this small case series. So overall, 19 children were included. Mean age of first symptom was 31 months. 5, so about 1/4, presented with extraocular RB. About 42% were effectively transferred to Pakistan. And at the end of follow-up, again, about just over 25% of patients were confirmed dead. 6 So 31% confirmed alive and 42% unaccounted for, lost to follow. So there are so many other interventions done across the world, in Africa and other places, trying to give hope to these little children from low and middle income countries. We're now enrolling children for the 2024-2027 global study, which has nearly doubled the number of participating centers. We're hoping to capture more cases and show better outcomes. Thank you.